Good morning, everyone. It's my pleasure this morning to introduce Richard Cheng. For those of you who don't know, I actually met Richard now about 15 years ago when he was applying for fellowship and I was a fellowship director. I think Richard stood out immediately during those interviews, and we were lucky enough to recruit him to our program. And he had decided that he wanted to focus on a research scholar pathway and was unfortunate enough to end up with myself as a mentor. Despite that deficit, he was able to have a very successful sort of research scholarship. We were just chatting about a paper we published together during that time. And then when he graduated from the heart failure program at UCLA, again, we were really lucky to recruit him up here. And I think anyone who knows or has worked with Richard knows that he is probably one of the hardest working individuals you will ever encounter. He seems to be everywhere, and if you look at his CV, it really reflects that. At this early stage in his career, he's published over 100 sort of manuscripts. He's on ISHLT editorial boards, heart editorial boards, does multiple activities for the ACC as well as the cardio-oncology, and it's just a really amazing for me being able to watch him over this time where he has really established himself as a leader in cardio-oncology in the country, and that has been really great for the University of Washington and the division, because he's been able to reach out to the SCCA and Hutch and establish collaborative relationships that we never really had before, and that's really sort of led to the initiative he spearheaded, which we were identified as a cardio-oncology center of excellence this last December. So I'm looking forward to Richard's talk, Emerging Strategies in the Management of Transthyretin Cardiac Amyloidosis, and just want to again congratulate him on overcoming, having such a bad mentor during his fellowship and still managing to succeed in his career. So take it away, Richard.
Good morning, everyone. And Rob, thank you so much for the kind words and all the mentorship and support you've given me over the years. I do want to say I spent, some of you may know this, so I spent some time in Rob's research lab as an intern. And even though I decided not to pursue basic science or translational research, I think a lot of the skill sets I got from Rob have really stayed with me and helped me with my clinical research in epidemiology. So I want to thank you for all the support you've given me over the years. So today I'm going to talk about the management of transthyretin or TTR cardiac amyloid. You might ask why I chose this topic. The reason is I think this is a very important topic and it's relevant to all of our practices. Over the last decade, there's been a huge revolution in terms of how we diagnose and treat TTR amyloid. And I'll show you why this is so relevant in the following slides. These are my disclosures. I do not have any direct financial disclosures. I am going to talk about the off-label use of RNA silencers for TTR cardiomyopathy, including with inotersen and pertuserin. So over the next 45 minutes, I'm going to focus really on 3 key objectives. I want you to keep this in mind as we go through the slides. So first, we're going to talk about best practices for the accurate diagnosis of transthyretin cardiac amyloid. I'm going to abbreviate this as TTR cardiac amyloid throughout the talk. We're going to reveal the role of standard heart failure management. Many of you may hear various things. We should or shouldn't use these therapies. You'll see that many of these patients actually have LV dysfunction. It's not only HFpEF. Many patients with cardiac amyloid do have LV dysfunction. And then I'm going to provide an overview of targeted therapies for TTR cardiac amyloid. And this is where a lot of the recent research has really been in. It's a very exciting time to be in the field because there's been so many clinical trials really targeting the various pathways for TTR cardiac amyloid. So I'm going to start by touching base briefly. So what is amyloid and why are we talking about this? Many of you know amyloid is not a single protein. It's a class of proteins. And essentially this can occur whenever you have protein that misfolds, and it's going to stick to various tissues depending on the type of amyloid. When we think of cardiac amyloid, there are two very common types. We think of light chain amyloid, and what this is, it's your bone marrow. It's going to overproduce a clonal plasma cell. As you know, plasma cells produce antibodies. So when you overproduce a single clone, it's going to overproduce a class of antibodies, which are made of heavy and light chains. What can happen is if you overproduce one antibody, your body can't clear all of this, and then the light chain fragments are going to misfold, and it's going to deposit in various organs. It likes to go to the heart and the kidney in the case of light chain amyloid. We're not going to talk much about this or at all through the rest of the slides, mostly because this is really an oncologic disease. You need to really keep this in mind because you have to have this in a differential, and it's a real emergency if you encounter this. I'm going to focus heavily on TTR amyloid, and the reason is as cardiologists, we're all going to see this. If you don't think you've seen it, you may be missing cases, but this is exceedingly common. So what is TTR amyloid? This is a protein that your liver produces and makes TTR, which is composed of 4 identical subunits. It has a normal function in the body by transporting vitamin A as well as T4. In addition to being produced in the liver, there's a small amount that's made in the choroid plexus as well as the retina, but the vast majority is made in the liver. What happens with this TTR is if it dissociates into monomers, it then destabilizes, it's going to misfold, and when it misfolds, it can make amyloid that's going to deposit in various organs. In the case of TTR amyloid, it likes to go to the heart as well as various tendons, and you're going to see patients develop carpal tunnel syndrome and spinal stenosis. For TTR amyloid, there are 2 main reasons why the protein can misfold. The first, on the left, we think of hereditary or genetic type. TTR, the terminology for this is really variant TTR or TTR-V. And the age of presentation is variable between 30 to 80 years, depending on the specific point mutation. There are a number of different mutations, as you can see on the middle here. In the United States, we usually encounter V122I, which is encountered in about 3 to 4% of African Americans. However, the penetrance of this is actually much lower. It's about 25% based on population studies. So even though many African Americans carry this variant, the majority will not develop heart failure, the majority will not develop cardiac amyloid. We also encounter a lot of T60A, which is common in individuals from Northern Ireland. I think the other thing to keep in mind is that depending on the specific variant, the presentation can be very different. In Europeans, many of these variants will present with predominantly neuropathy or mixed neuropathy and cardiomyopathy. For the V122I, this is mostly cardiomyopathy, and that's why we focus so heavily on this. The other presentation that's very common is the age-related TTR, otherwise known as wild-type TTR. For this, it's not heritable, and there's no geographic disparities. And I would say as cardiologists, we're going to see mostly wild-type TTR. I can tell you for my practice now, the vast majority of the patients I see are age-related TTR because it's just so much more common. So let's look at a case here. We have a 72-year-old male who's newly diagnosed with HFpEF. The ejection fraction of about 50%. He does have left ventricular hypertrophy, mild CKD, bilateral carpal tunnel syndrome. He does not have a history of hypertension or aortic valve disease. So his LVH is unexplained. You're worried astutely that he may have cardiac amyloid. So what do? You send serum and urine immunofixation. And what you find is the kappa fragment is a little bit elevated. Lambda is normal, but your kappa to lambda ratio is a little bit elevated at 2.5, where the reference range is 1.9. So my question for you is, which of the following would you recommend? Would you now pursue a nuclear pyrophosphate scan, a cardiac MRI, a fat pap biopsy, or an endomyocardial biopsy? So I want you to keep this in mind as I go through the following slides, and we'll go back to this question. So when do we worry about cardiac amyloid? There are a number of red flags that you're going to encounter in day-to-day practice that should really raise your alarm for cardiac amyloid. The first one is on echocardiography. If there is LVH, septal wall thickness of greater than 1.2, and a low voltage on ECG, essentially a voltage mass mismatch, you should think of cardiac amyloid. In addition, amyloid likes to deposit throughout the myocardium, so you're also going to have RV wall thickening as well as valvular involvement. If your patient is highly intolerant to beta blockers or ACE inhibitors and ARBs, then you should also worry about cardiac amyloid. If your patient has a history of hypertension and suddenly what you're finding is their blood pressure is dropping, you're taking them off all their medications, you should probably think about cardiac amyloid, get an echo on them, see if you have the voltage mass mismatch, really work them up. Additionally, bilateral carpal tunnel syndrome, as I'll show you, for this, there's a very high prevalence of cardiac amyloid. On the bottom, on the left, it's patients with light chain amyloid. On the right, it's patients with TTR amyloid. So there are specific scenarios that we worry more about TTR amyloid. So older individuals with HFpEF and carpal tunnel syndrome or spinal stenosis, this should really raise your alarm that you should look for TTR amyloid. African Americans are older with HFpEF but do not have a history of hypertension. Again, you should really worry about TTR amyloid. Newly diagnosed hypertrophic cardiomyopathy in the elderly. There is some overlap in terms of phenotype between HCM and TTR amyloid, but you should really think about this if an older patient is diagnosed with HCM. We worry about this in patients with low flow, low gradient AS, particularly those that get TAVR and that they do not clinically improve and they have LVH, they probably have TTR amyloid. And those with a family history of TTR amyloid, you should worry about it. So how do we diagnose cardiac amyloid? So this is taken from a consensus statement from Michelle Kittleson, published last year. So if you have a clinical suspicion for this based on a history, ECG, and echo, the next thing you should really do is you should look for monoclonal light chains, because again, light chain amyloid is an emergency. How do we do this? You want to send serum-free light chains and serum and urine immunofixation. If these are abnormal, then you go down the pathway on the left. You have to biopsy the individual. We usually recommend biopsying a targeted involved organ, such as the heart or the kidney. And if this is abnormal, and then the patient probably has light chain amyloid, you should send them to oncology. However, if your light chains are normal, your immunofixation is normal, then you can go down the pathway on the right. For this, you can pursue a nuclear pyrophosphate scan, and it's considered diagnostic if there is visual uptake of 2 to 3 or heart to contralateral ratio greater than 1.5 at 1 hour acquisition. And this is sufficient to confirm your diagnosis if the PYP shows uptake and you do not have light chains. For patients with TTR amyloid, I always recommend sending genetic testing, regardless of age, because there are implications for cascade screening. So I think there are 3 major points here, however, that I want you to keep in mind. The first is that SPEP and UPEP are not sensitive. So if you're going to send something, send immunofixation. Do not send SPEP, UPEP. Fat pap biopsy is not sensitive. For light chain amyloid, it's about 60%. However, for wild type TTR amyloid, data from Europe shows it's less than 20% sensitive. So it's not very helpful. So you can skip this, really target the involved organ. And then pyrophosphate scan is only helpful if your light chains are negative. So if your light chains are abnormal, you have to pursue a biopsy. So going back to our clinical case, which of the following would you recommend for a patient suspected to have cardiac amyloid with slightly abnormal light chains? A pyrophosphate scan, you cannot do this, right? Because the light chains are abnormal. Cardiac MRI, not that helpful. I'll tell you if the patient has amyloid, does not type it. Fat pap biopsy, low sensitivity. So in this case, you have to biopsy the patient. Once you make the diagnosis, the question is, how do you risk stratify the patient? There are different staging systems in place. The first one commonly used is from the Mayo Clinic. It utilizes troponin T and NT-proBNP. We have a system from the United Kingdom, from the National Amyloid Center, that uses EGFR and NT-proBNP. And then recently, we derived this score from Columbia University's data set, where in addition to the parameters used in the Mayo and the UK risk score, it turns out if you add daily dose of Lasix, it incrementally adds risk stratification. And as you'll see, it stratifies patients very well. If you're low risk, median survival is 90 months, high risk, less than 2 years. So it turns out that diuretic dose may be the strongest predictor, and it's actually more accurate by itself than the Mayo or the UK risk scores, but together, it's highly predictive of outcomes. So again, why are we talking about amyloid? How common is this? I mean, I think the historic perspective, oftentimes we hear amyloid is a zebra, and it's actually turned an orphan disease by the FDA. So what does this mean? They think it affects less than 200,000 individuals in the United States. Based on the US population, this translates to a prevalence of about 50 to 60 per 100,000. So not that common, but is this accurate? So this is data looking at Medicare in the United States from 2014 with individuals with more than 1 hospitalization for cardiac amyloid. At the time from ICD-9, there were no systemic codes for cardiac amyloid. So they looked at codes for patients with systemic amyloid and then codes for heart failure. So if you look at this, in 2012, the prevalence was about 55 cases per 100,000 for those hospitalized. And if you remember, the threshold for rare disease is 50 to 60, so it really approaches that threshold. So I would make the argument that TTR amyloid is probably not a rare disease. Disease estimates shows already close in 2012, at least for hospitalized patients. In addition, it's likely underestimated in this study because they did not have specific codes, and this was based on an aggregate of coding. And we know that since 2012, there's increasing recognition. We don't have great data since 2012, so I did a quick PubMed search, and this is what I found. These are publications with transthyretin cardiac amyloidosis in the key terms. In 2013, this is when I started at University of Washington, what you see is there's already been a steady increase. And then Tafamidis, which is a TTR stabilizer, the clinical trial for this was announced in 2018. Since then, you see this dramatic increase in the number of publications on TTR cardiac amyloid. So I would make the argument that TTR amyloid is not a rare disease. It's much more common than all of us realize. And this is why it's so important that you look for it in your patients. So what do we see in the community? This is data from the Mayo Clinic. This is a population-based cohort study to determine the prevalence of TTR in patients with HFpEF. They looked at 1,235 consecutive patients with HFpEF in Minnesota, median age of 80. So older individuals with HFpEF. And of these patients, they systematically screened 286 with nuclear PYP scans to look for undiagnosed TTR amyloid. So on the left, what you see is a clinical diagnosis of TTR is not that high. But when you systematically screen this, it turns out that more than 5% of older individuals with HFpEF probably have TTR amyloid, and many of these are undiagnosed. When you stratify this by gender, almost 10% of men who are older with HFpEF will have TTR amyloid if you look for it. And when you stratify this by age, it's even more alarming. So for individuals who live to be 90 years old, if they present with HFpEF, greater than 20% have TTR amyloid if you look for it. So this goes back to, we all probably see this in clinical practice, whether we realize it or not. What about TAVR? I like to put this here because I know we have a number of interventionalists in the audience, and they might ask, well, you know, like I like to put TAVRs in, why do I care, right? It turns out that a lot of your patients that you're putting TAVRs in, especially if they're older, probably have TTR amyloid. So this is a single center study from Columbia University. They looked at 154 older patients referred for TAVR. And of the total cohort, when they systematically looked for TTR amyloid with nuclear phosphate scans, it turns out that 16% of these older patients referred for TAVR had TTR amyloid. And if you look at the male cohort, it was greater than 20%. So what are the risk predictors for patients referred for TAVR more likely to have TTR amyloid? Tends to be older males, those with low full low gradient AS, particularly if they do not get better after TAVR, if they have abnormal voltage to mass ratio, and there are a host of echo findings, which will raise the suspicion. Again, increased LV wall thickness, abnormal strain. And this is a recent summary of all these different cohorts that was published very recently. And what they show highlighted in red, in particular, these are cohorts. If you see this, you should really, really look for TTR amyloid. So in HFpEF, older individuals, 12% across all studies. Patients referred for carpal tunnel syndrome, about 7%. Patients with hypertrophic cardiomyopathy, if you look for in older individuals, about 7%. And aortic stenosis, about 8%. And in a study where they did autopsies on unselected elderly individuals, it was greater than 20%. So again, very, very common. So in clinical practice, what we really see is patients with heart failure as a heart failure cardiologist. But I think for many general cardiologists, interventionalists, and EP, you're going to see all this in your regular practice, right? You see atrial arrhythmias, conduction disease, valvular heart disease, and our orthopedic friends are going to see carpal tunnel syndrome, spinal stenosis. And I think really we're only seeing a tip of the iceberg because all of these other patients, many of them are going to have undiagnosed TTR amyloid. And I encourage you to look for it when you encounter this because you're going to find it if you look for it. And it's really important to diagnose these patients early. So I'm going to focus now on treatment for cardiac amyloid. And this slide really lays a framework for how we manage these patients. It's really startling in terms of, you know, I gave a similar talk at Graham Rounds, I think it's maybe 4 or 5 years ago, but the landscape has really changed. 4 or 5 years ago, almost none of this existed in terms of data for how we manage these patients, how we treat light chain amyloid, and more particularly how we manage patients with TTR amyloid. So I'm going to go back to our patient. Our 72-year-old patient has diagnosed TTR wild-type cardiac amyloid. A follow-up echo shows mildly reduced ejection fraction of 47%. He's volume overloaded on exam, does not have AFib or coronary artery disease. Which of the following heart failure medications would you recommend? So, we have the pillar, as 4 heart failure classes of medications: beta blockers, ACE inhibitors, ARBs, Entresto, spironolactone, SGLT2 inhibitors. In addition to that, we can give furosemide to treat the symptoms. So which of the following medications would you recommend for your patient? And you can select all of the following that apply. So when I think of treating TTR amyloid, I'm a very simple person, so I have this very simple framework here. I like to treat the symptoms. I diurese my patient to alleviate volume overload. And then if they have a low ejection fraction, I think about starting heart failure guideline-directed medical therapies, although the data is a little bit questionable. You want to manage your patient with arrhythmias because it's exceedingly common, all types of arrhythmias. Amyloid goes everywhere in the heart, so everything's going to be impacted: the atria, the ventricles, the conduction system. And then if your patient is confirmed to have the disease, then you can give them focused treatment with TTR stabilizers or consider them for clinical trials. And if everything fails, you should consider heart transplant. So this is a framework that we recently published looking at the progression of TTR amyloid. So we have the preclinical phase where you can really monitor patients. And in this early clinical phase, where they're going to have this very slow decline. And I think what I want to emphasize is you want to diagnose your patient early. Ideally, you want to diagnose them just during this early clinical phase, because if you can stabilize them here, you can treat them. You want to treat their arrhythmias, start them on diuretics, start them on Tafamidis. You can really slow their progression of disease, and hopefully they won't ever develop significant heart failure. However, once they reach this restrictive heart failure stage, what you're going to find is that you're going to have these peaks and valleys because they're going to bounce in and out of the hospital. And between this, their clinical status is going to wax and wane. And this is where you're going to start thinking about starting them on heart failure medications. I will often implant them with cardiomems or volume management. Again, once they reach end-stage heart failure, this is really a point of no return. Unfortunately, we do not have great therapies to remove amyloid, only to stabilize the patient. So when you get to a stage, this is when we start to think about palliative care or referring them for heart transplantation. So going back to heart failure therapies, right? I mentioned it's a bit controversial. And why is it controversial? I want to spend a little bit of time on the physiology of TTR amyloid because I think it's really important to understand the underlying physiology to really understand why these patients may not tolerate standard heart failure guideline-directed medical therapies. So many of you recall this from medical school or your training, where this is a pressure volume loop. This line on the upper left is your contractility line, ESPVR. This line on the bottom right is EDPVR, represents diastolic function. And the slope is your arterial elastance slope, or EA slope. So in this picture, what we have is in gray. This is your normal individual. The colored lines are patients with various types of amyloid, wild type or variant TTR. And what happens to your patient with cardiac amyloid is your ESPVR line moves downward and to right, so have decreased contractility. EDPVR moves upward and to the left. So these patients will have abnormal diastolic function. So for any given volume, they're going to have a higher pressure. In addition to this, they have an altered ventricular vascular mismatch with an altered arterial elastance slope. This is why, if you, for example, if you try to vasodilate your patient with afferent reduction, because there's abnormal ventricular vascular mismatch, they may not tolerate it. They're going to become hypotensive. They cannot augment their stroke volume. Additionally, we know that the cardiac output is reduced, and the rationale for this is if this is a stroke volume going from left to right in this pressure volume loop, and what you see is that this is reduced in all types of TTR amyloid. So these patients tend to be very heart rate dependent. So if you beta block them, you decrease their heart rates, they cannot augment the stroke volume because of their abnormal ventricular vascular mismatch, and they're going to end up feeling poorly because their cardiac output is going to drop. So despite this, what I mentioned previously is you want to give them diuretics, right, to alleviate their symptoms. However, it turns out that diuretic dose is a strong predictor of mortality. So this is data that we published, again, from the patients followed at Columbia University, 209 patients with TTR amyloid, mean age of 73, majority male, majority wild type. And it turns out that diuretic dose strongly stratifies these patients. You see this marked contrast where for patients not on diuretics, median survival goes beyond this curve, beyond 5 years. If they're on greater than 1 milligram per kilogram of diuretics, their median survival is exceedingly poor, less than 2 years. We do not think diuretics kill your patients. Instead, we think it's really a marker of worsening severity. So what you should do is you should give your patients diuretics if they're volume overloaded. But if you're increasing their diuretics, you should really worry that they're starting to get worse and think about referring them for advanced therapies. And I mentioned earlier that direct dose, when added to traditional risk scores, is a very strong predictor of outcomes. It adds to the discrimination in terms of predicting mortality for your patients. What about digoxin? You're often going to hear you should avoid digoxin. This may or may not be true. So this is data from Mayo Clinic as well as Cleveland Clinic. So from the Mayo Clinic, this is a single center study of 107 patients with light chain amyloid. Most patients were given digoxin for the indication of rate control for atrial fibrillation or atrial flutter. During follow-up, 50% stopped digoxin due to physician preference, 11% had significant arrhythmias, and 5 patients had terminal arrhythmias. So a very low proportion of patients ended up having terminal arrhythmias. Keep in mind, this is a very sick population because these all had light chain amyloid. From the Cleveland Clinic, they also published their series of 69 patients with cardiac amyloid. This was a mixed cohort of TTR and light chain amyloid. Major indication was again for rate control. For this, 12% had arrhythmias or toxicity, and no deaths could be attributable to digoxin. So in general, digoxin may be tolerated. The authors concluded that digoxin can be considered with rigorous patient selection. You might ask, how do we operationalize this in clinical practice? So what we would typically recommend is do not use this for heart failure. But if your patient has refractory atrial fibrillation, very hard to control, as I mentioned, it's hard to beta block these patients because they tend to not tolerate it. So you can consider digoxin if you closely monitor their levels and their renal function. What about beta blockers? There's limited data on this. So this is survey data from 11 Italian centers. This was a descriptive study looking at beta blockers. They looked at the first and the last visits cross-sectionally. They do not have data on outcomes. But I put this here really to highlight why patients with amyloid may be on beta blockers. So this study consists of 642 patients with cardiac amyloid, mixed genotype, light chain as well as TTR amyloid. And of these patients, the majority of patients were on beta blockers for atrial fibrillation. During follow-up, if patients were started on beta blockers, again, majority were started on them for arrhythmia management, for atrial fibrillation or for ventricular arrhythmias. During follow-up, 43% of patients stopped beta blockers, and the major reason was because of intolerance due to worsening heart failure. So you might ask, how does this impact outcomes? Again, there's not much data on this. So we looked at this using the data set from Columbia University. I'm showing you direct adjusted survival curves on these patients, all with TTR cardiac amyloid. In this study, for these patients, there was no association of beta blocker use with mortality. However, if you look at patients who were prescribed beta blockers on follow-up, it turns out there was a survival benefit if you stop beta blockers in patients who were not tolerating it. And during follow-up, about half of patients stopped beta blockers. The major reason was these patients have worsening heart failure. So these patients, if you stop it versus patients who continue beta blockers, they tended to do better. And the results were consistent regardless of baseline use or time-varying use. What about ACE inhibitors or ARBs? And again, this is somewhat controversial, but at least in this cohort, there was no survival benefit upon follow-up regardless of ejection fraction. However, what you see is there's some divergence of the survival curves about 2 years, and there may be a hint of survival benefit, although it did not reach significance. So what I would say is, if your patients on ACE inhibitors or ARBs, you can continue if they're tolerating it. But I do not routinely put patients on ACE inhibitors or ARBs unless they meet the standard heart failure indications. What about MRAs or spironolactone? In this study, again, there was no survival benefit associated with MRA use. However, there was a more recent study published in the TOPCAT data by Brett Sperry. And what they did is they looked at the TOPCAT clinical trial. Many of you recall the TOPCAT study randomized patients with HFpEF defined as ejection fraction greater than 45%. They were randomized to spironolactone or placebo. So they looked at this data set retrospectively, taking a cohort that was enriched for cardiac amyloid. So patients with echo data with S prime velocity less than 6 centimeters per second. And this has been shown to be the strongest predictor for having TTR amyloid from the UNVEIL study, which was published by Matt Maurer previously, and including patients with LVH. For this total cohort with echo data, spironolactone was associated with improved survival for all comers with HFpEF. And then I'm showing you on the right here, so that red are patients enriched for cardiac amyloid, blue are patients not enriched for cardiac amyloid, the solid line are patients on spironolactone, dotted line are patients not on spironolactone. What they showed is that regardless of the set that was enriched for cardiac amyloid or not enriched for cardiac amyloid, there was a survival benefit for spironolactone. So this data suggests that there may be a survival benefit if you give spironolactone to patients with cardiac amyloid, keeping in mind that this was based on surrogate diagnostic parameters for cardiac amyloid, and none of the diagnoses were actually confirmed. So what do the guidelines say? So I like this recent publication because it really summarizes the aggregate of data. So on the top here, what we have are the ESC guidelines, the German guidelines, Canadian guidelines, the data from American Heart Association, and then Japanese guidelines. So for loop diuretics, they consistently recommend using loop diuretics for our patients with TTR amyloid because, again, you really want to diurese your patient, alleviate the symptoms. What about beta blockers? In general, all the guidelines say that you should avoid beta blocker use, and if you use it, you should use it cautiously because patients may not tolerate it. What about ACE inhibitors or ARBs? Again, you should avoid it or use it very cautiously because patients may become hypotensive. What about sacubitril valsartan or Entresto? The most guidelines do not have any recommendations because of lack of data. The AHA does have some recommendations. They say you should use it cautiously or you should avoid it because, again, they worry about hypotension. What about MRAs or spironolactone? I showed you the data from TopCat, but the recommendations are a little bit inconsistent across the guidelines. They either do not have a recommendation or they have a weak recommendation for using it. In general, where we use it is we combine it with loop diuretics to really augment diuresis, but also for potassium sparing. And I put this table here because it really summarizes why there might be benefit for use of these heart failure guideline-directed medical therapies in cardiac amyloid and the associated concerns. So I think there are some real concerns that if you give this to patients, they may become hypotensive, they may become very symptomatic. And what about SGLT2 inhibitors? This was not really addressed in the guidelines. Many of you know this recently achieved the FDA indication for HFpEF. Many of these patients have HFpEF. In addition, we already know they work in HFrEF. So essentially, you can give it to all patients with amyloid. So there may be some osmotic neutral diuretic beneficial properties as well as benefits for lowering the PA pressures. So I have been giving these to our patients, but I think there's almost no data on this, so you should use it with caution. There is a very small study which is ongoing at Columbia University right now, really looking at what happens when you administer these to patients in terms of their echo parameters as well as their clinical functional status. So going back to our patients, what would you recommend for the patient with TTR wild-type amyloid, a mildly reduced ejection fraction, volume overloaded? So the data really supports, the use of spironolactone based on the TopCat data, and then you should give them Lasix based on the guidelines. But for all these other therapies, we do not have enough data to recommend it. I'm going to touch base briefly on arrhythmias now, just because these are all very common. So for your patient with cardiac amyloid, you should really worry about atrial fibrillation. Depending on the study, the prevalence is a bit variable, but the largest study showed that about 70% of patients are affected by atrial fibrillation, so exceedingly common. I routinely put Holters in all my patients, even if they do not have known AFib. In addition, patients with AFib are very likely to have intracardiac thrombus. Many of these patients will have conduction disease because amyloid goes everywhere, affects the conduction system. We also worry about ventricular arrhythmias because it also likes to go to ventricles. It's going to irritate the myocardium there. If your patient has atrial arrhythmias, this is data from Mayo Clinic for patients with amyloid atrial arrhythmias referred for cardioversion. You should always, before you cardiovert them, consider doing a TEE and be very cautious. So in this study, they included 58 patients with cardiac amyloid, mixed TTR and light chain amyloid. On TEE, 13 of these patients had thrombus. And many of these patients had their procedures canceled, mostly because of the presence of thrombus. And this included 2 patients with atrial fibrillation for less than 48 hours, and 4 of them had therapeutic INR for greater than 3 weeks. So regardless of anticoagulation status, you should always do a TE on your patient with amyloid and atrial fibrillation before cardioversion. So take-home points here are that there are high rates for atrial fibrillation. You should anticoagulate your patient regardless of CHA2DS2-VASc score. There's a lack of data on left atrial appendage closure because these patients are so prothrombotic that you can form thrombus on top of the left atrial appendage closure device. You should be very cautious with the digoxin. And if you need rhythm control, you should use amiodarone. What about ventricular arrhythmias? So because of the patchy amyloid infiltration and microvascular ischemia from the deposition everywhere, these patients are very prone to VT. If you stick Holters on your patients, you're almost certainly going to find VT in your patients. But based on implantable loop recorder data, most of the mortality is driven by bradycardia or PEA rather than VT or VF. So it becomes a little bit questionable whether you should give them ICDs. However, if you give them ICDs, there are studies showing that appropriate ICD therapy is present in about 32% of patients at 1 year, about 9% per patient afterwards. So, the question becomes, when do we use ICDs? So clinically, we tend to use it for secondary prevention, but it's very questionable when you should consider primary prevention beyond the standard indications. What do the guidelines recommend? So 2015 ESC guidelines states that there are insufficient data to provide recommendations for primary prophylaxis in patients with cardiac amyloid. What do the American guidelines recommend? So 2017 AHA-ACC-HRS guidelines states that whether ICDs are effective for primary prevention for sudden cardiac death is uncertain, but many deaths do not appear to be preventable by an ICD. And this is because based on some studies, many of these patients die from PEA instead. Because of this, the decision to implant should be individualized because the data remain too limited to allow for formal recommendations. So again, we recommend this for secondary prevention if their mortality is going to be low at 1 year, but we don't recommend this for primary prevention unless they meet standard recommendations. So going back to this framework here, I really want to emphasize, take-home point is you should really try diagnosing these patients early. You do not want to wait till they present with restrictive heart failure because the treatment for this is uncertain. So what are our take-home points? What do we know for heart failure therapies? Loop diuretics can be used to alleviate symptoms. Beta blockers are not well tolerated in advanced cardiac amyloid due to restrictive filling and ventricular vascular decoupling because many of these patients become hypotensive. Atrial and ventricular arrhythmias are very common. You should always anticoagulate your patient with atrial fibrillation. For patients with end-stage disease, you can consider heart transplant. So what are areas for research? I think we really need more data on the use of heart failure guideline-directed medical therapies. For example, SGLT2 inhibitors and amyloid. We need data on the use of ICDs for primary prevention. And for heart transplant, we don't really know when we should refer these patients, particularly in the era of contemporary therapies, which, patients do so well on them. We don't really know, like, when should we refer the patient, right? I mean, you don't want to wait till they're too sick, but we also don't know whether traditional heart failure indications really apply for these patients. So I'm going to spend the rest of the time talking about specific treatments. And as you'll see, there's been a huge emergence of therapies for treatment of TTR amyloid over the last several years. So I think this is very elegant in terms of these therapies because it really follows the pathophysiologic mechanisms for TTR amyloid. So if you remember, the liver makes this tetramer, which can then misfold into monomers, and this can further misfold and form amyloid. So the first target is really to decrease TTR synthesis, and you can do this with liver transplant, RNA knockdown agents, or with CRISPR. And then a little bit downstream of this, if you can stabilize the tetramer here, this cannot dissociate. If it doesn't form a monomer, you can't form TTR. And Tafamidis is a TTR stabilizer, which is the only FDA-approved treatment right now for cardiac amyloidosis. Even more downstream of this, patients will often ask, once I have amyloid deposits, what can we do? There's been a lot of interest at removing these amyloid deposits, but none of these have really made it to market. Some of them are in clinical trials, but I think the jury remains out on these treatments. So I'm going to focus mostly on TTR stabilization because this is where most of the data is. So going back to our patient, he has NYHA functional class 2 heart failure with confirmed wild-type TTR. Which of the following therapy would you start? Would you start a TTR stabilizer, a silencer, a degrader, or none of the above? So I'm going to talk a lot about Tafamidis since this is FDA approved, but what the mechanism of action for Tafamidis is this is a TTR stabilizer. Tafamidis binds to TTR at the T4 binding site. So remember, the TTR tetramer normally transports vitamin A and as well as T4. So Tafamidis binds there to really stabilize this and it prevents it from dissociating. So the landmark study from this was the TRACK study where they randomized patients with TTR cardiomyopathy to Tafamidis at 20 milligrams versus 80 milligrams versus placebo. And their analysis method was a bit interesting. They used a Finkelstein-Schoenfeld method. Some of you may be familiar with this, but this is a non-parametric method to weight the endpoints using a win ratio of clinical importance. So the primary endpoint was all-cause mortality followed by cardiovascular hospitalization using this win ratio method. And what they showed is there was a 30% relative reduction in all-cause mortality. The number needed to treat was 7.5 at 30 months. So significant benefit, and because of this, we give this to all our patients now. When they looked at this based on subgroups, whether it's based on TTR genotype, variant versus wild type, NYHA functional class, or the dose used in the study, this was consistent across all subgroups. If you look at hospitalization, this was again consistent across all subgroups, except patients with NYHA functional class 3 heart failure had increased hospitalization. You might ask, this seems a bit paradoxical. It turns out that we think the reason for this is because this is driven by improved survival in these patients. Because of that, they live longer, so they're more likely to be hospitalized. So this again emphasizes the importance of early detection so that you can really treat your patient earlier to prevent them from getting worse. What about long-term outcomes? So this was long-term data from the ATTR-ACT trial, where they looked at patients who were continued on tafamidis long-term. For patients on placebo, after 30 months, they entered the open label extension phase, where patients from placebo then transitioned to tafamidis, and then they extrapolated outcomes based on patients who remained on placebo using a gamma distribution model. And what they showed is regardless of whether you're on tafamidis to begin with compared to placebo, there was benefit, or if you started tafamidis late compared to this extrapolate placebo, there was still a benefit. And there was a 41% reduction in relative risk for mortality for those on tafamidis compared to placebo. Earlier initiation is critical because you see this early separation in these survival curves. And I think the other take-home point here, which is very interesting, is median survival for patients with TTR amyloid on tafamidis approaches about 5 years. The reason why this 5-year median survival is important, many of you recall for any heart failure patient, median survival is about 5 years. And we often hear, if you have amyloid, it's very bad, right? We worry about them more than our average heart failure patient. If you put them on tafamidis, arguably the survival is going to be similar to your other heart failure patients. However, I think the thing to keep in mind with tafamidis is that the cost is very high. So the current cost is $225,000 per year. So this was a cost-effective analysis from Sanjeev Shah's group, where they looked at a Markov model showing that the ICER is $880,000 per quality-adjusted life year. So this far exceeds what economists state is cost-effective. Economists will tell you this should be about $100,000 per quality. So based on this study, they say that you need a 92.6% price reduction on the cost of tafamidis for it to be cost-effective. And this shows you, these different points here. But essentially, you need a huge price reduction based on the current market cost for this to be cost-effective. And to put this into perspective, for dapagliflozin, an SGLT2 inhibitor, it's about $68,000 per quality. So tafamidis is very, very expensive. You might ask, how do we get this to our patients? So this is data from OHSU looking at 50 patients where they prescribed tafamidis. The median 30-day out-of-pocket cost was initially about $1,900. So this is very high for many of our patients, right? I mean, how can they afford this? However, despite this, about 86% of patients obtain the drug. You might ask, how did they obtain the drug? It turns out that the majority of patients will need co-payment assistance from the foundation manufacturer. I can tell you here what often ends up happening is almost all my patients will get approved by their insurance, but the copay will be very high, and then we go through foundation or Pfizer assistance. And at least in my experience, all my patients except the one has been able to get tafamidis. This seems very attractive. However, there's a lot of paperwork involved. Not all patients qualify because of competing financial commitments, and the funds will eventually run out. So now I'm going to move on and talk about a little bit about TTR knockdown. So I mentioned liver transplantation, which we don't really use very much anymore. You can consider silencers or CRISPR. So what data do we have on TTR knockdown? There have been trials in polyneuropathy. There was an Apollo trial looking at partisiran, which is an siRNA, and then the NEURO-TTR trial looking at inotersen, which is antisense oligonucleotide. So these are studies in patients with TTR variant polyneuropathy, and in both these studies, they showed a marked reduction in the progression of neuropathy. So very effective for these patients. You might ask, as cardiologists, why do we care? What's the data on TTR cardiomyopathy? So for patisiran, there was a post-hoc analysis of Apollo for patients with cardiac involvement, and they showed a decrease in LV wall thickness, improved strain, and a decrease in NT-proBNP. There was a single center open label study with inotersen, which looked at patients with TTR cardiomyopathy. Again, they showed benefit at cardiac surrogates with decreased LV mass and thickness decreased BNP, improved 6-minute walk. And there are ongoing clinical trials specific to TTR cardiomyopathy, first generation patisiran, and second generation with eplontersen and vutrisiran. And the readout for these studies is expected to come out in about 1 or 2 years. So I would say stay tuned because I think there's a lot of excitement for these therapies for TTR cardiomyopathy. What about CRISPR? I'm going to talk a little bit about this because patients are going to ask you about this. You're going to hear a lot about this. And for example, last week at the Grand Rounds for decreasing ApoA, I know there was some discussion also on the use of CRISPR. So current TTR knockdown is based on the paradigm of degradation of TTR mRNA. This is limited by the need for ongoing administration of therapies. So our patients will need sequential injection or infusion of the current therapies, and there can be side effects over time. So for example, some patients will develop infusion reactions, and some of these, for example, with inotersen, some patients develop thrombocytopenia or glomerulonephritis. For TTR, this is a very attractive target for CRISPR because TTR amyloid is a monogenic disease. TTR knockdown has limited additional physiological effects, and TTR is mostly made in the liver, which makes it a natural target for lipid nanoparticles, particularly with GalNAc. Going back to CRISPR here, there was a pilot study. Many of you are familiar with this. This was published in New England Journal about 6 months or a year ago. They looked at 6 patients that were dosed with a high and a low dose of NTLA 2001 lipid nanoparticle. And I really encourage you to go to the New England Journal website because they can explain this better than I can. But essentially what this is it's a lipid nanoparticle delivery system that's liver tropism that delivers messenger RNA with a Cas9 protein and a single guide RNA that contains a TTR gene-specific sequence to really be uptaken by the hepatocytes, so very targeted. When it's uptaken by hepatocytes, this results in sequence-specific cleavage of the TTR gene and frame shift mutation that prevents production of functional TTR. So essentially it knocks down TTR. And what they showed is the knockdown is early and is sustained at least to 28 days. So in this pilot study, at 28 days with a low dose, there was 52% knockdown. With a high dose, there was 87% knockdown of TTR. So it appears very effective. And this can be very attractive, right? Because a single infusion may result in permanent silencing. So there are implications for adherence and cost. Patients who don't want to do sequential injections, one injection, it may be sufficient to silence TTR long-term. However, I say you should approach this with caution. It's a very small N, limited follow-up time, so we need more data on this. Larger sample sizes, longer follow-up time. There are also some concerns for genotoxicity or oncogenic effects if there's off-target effects, although the preclinical data showed that this approach appears to be very precise. So I think this is very promising. There's going to be more data. Right now, they're doing this in England, but there aren't ongoing studies in the US that I'm aware of. So I'm going to end by talking about TTR suppression briefly. Sorry, not TTR suppression, TTR degradation. There's very little data on this as well, I'll tell you, okay? There's been interest in using doxycycline as well as monoclonal antibodies to really remove TTR. The majority of these antibodies have not been effective. For example, anti-SAP, it has not made it to phase 3. They're no longer looking at it. There are some studies looking at PRX004, which will remove amyloid deposits. This is currently in entering phase 2 trials. So what data do we have on this? This was a recent systematic review looking at all of these other therapies. They concluded that available evidence does not support, at the present time, the use of any of these therapies. Keep in mind, this was published in 2020. As I mentioned, there are many ongoing trials, so I would say stay tuned for more data. So how do we put this all together? So if your patient is confirmed to have TTR amyloid, I showed you earlier what you should do from a heart failure standpoint and a arrhythmia standpoint. For disease-modifying therapies, if they have cardiomyopathy, whether it's wild type or variant TTR, the only treatment currently FDA approved is Tafamidis. If it turns out they have neuropathy, then you can consider putting them on patisiran or Tafamidis, patisiran or inotersen. And there are many other therapies which are coming down the pipeline specific for cardiomyopathy. And I think, many of the readout for these studies are going to be coming out in the next year or two. So again, very, very exciting time to be in the field, but it remains uncertain when or how these therapies will be implemented. So going back to our patients with MRT functional class 2 come from wild type TTR, which of the following therapy would you start? you would start them on tafamidis because it's the only therapy currently available, and none of these other therapies are available for cardiomyopathy. So what are our take-home points? What do we know? So there are two main strategies proven to be effective for treating TTR amyloid. If your patient has variant TTR polyneuropathy, you can silence production by giving them participin or inotersen. If they have cardiomyopathy, the only treatment is with tafamidis. What do we not know, and what are areas for research? So what do we do when we get better diagnosis with asymptomatic patients? For example, orthopedic surgeons are now sending me patients where they incidentally find TTR deposits after they do carpal tunnel syndrome surgery. We don't really know when to start tafamidis if they do not have cardiac involvements. And I think this remains an area of research. Will TTR silencers work for TTR amyloid? If so, should we combine TTR silencers with stabilizers? This is very attractive because if you can knock down TTR and stabilize what you make, theoretically, you can achieve even more durable the clinical course in terms of preventing patients from progressing. What about CRISPR? Is this going to be a durable, safe solution? I think we need more data on this. And as I already mentioned, we do not know if degraders or extractors are going to work. Many patients present late. What do we have to offer for them? And I think we focus so much on treatments. You know, we talk a lot about stabilizers, silencers, and degraders, but I think the real elephant in the room is going to be the cost of therapy, right? These are all very, very expensive. And I think in the patient interest, we're really to keep the two in mind and balance what's best for our patients from a holistic viewpoint. So I'm going to end here and take any questions. But I can tell you at UW-SSA, we do have a multidisciplinary amyloid program. We see both patients with TTR as well as AO amyloid, and they're experts in all the different disciplines as I show you here. And I'm fortunate to have collaborators from a research perspective, both at University of Washington as well as throughout the United States. I thank you very much.
Thanks, Richard. There's one question in the chat, but before we get there, can you just clarify one? You had put up heart transplantation as an option for those who had severe amyloid. Can you talk about recurrence rates in those patients, and does it really require transplantation and tafamidis to treat them? And I'm just wondering what the economics of that is.
Yeah, so I think that's a very valid question. So what do we do for TTR amyloid patients who have end-stage heart failure? So heart transplant is certainly an option for selected individuals. There's data from UNOS where when they look at the older era prior to 2013, it turns out that patients with TTR amyloid do much worse than other cohorts. In a more contemporary era, patients seem to do well. They do about the same from analysis from UNOS, but also from more limited data sets from CEDARS as well as from Stanford. In terms of what we do for these patients, in general, after you do a heart transplant, the thought is it takes so long for amyloid to deposit that they're unlikely to have recurrence. So for wild-type TTR amyloid, oftentimes we'll transplant them. We do not put them on therapy afterwards. For variant TTR, the concern isn't so much the deposition in the myocardium, it's more whether they're going to have progression of neuropathy. So oftentimes, I can tell you for my patients, I continue them on tafamidis as long as I can get it approved. There's very limited data on this. There was a recent series published from Columbia from Jan Griffin and Matt Maurer that looked at this. You know, small series can't draw definitive conclusions, but they gave them either stabilizers or even silencers for variant TTR and showed that, you know, they did well over time, it's well tolerated, but again, not enough to power hard clinical endpoints. So I think, you know, for patients with TTR, if they're wild type, you can transplant them. You probably don't have to worry about them afterwards. You know, if it took them 70 or 80 years to deposit amyloid, you know, it's unlikely to deposit amyloid to a meaningful state after heart transplant. For those with variant TTR, you should consider putting them on tafamidis because you don't want them to end up developing severe neuropathy.
Okay, thanks. There's a question in the chat from Bryce. It says, for studies evaluating new agents' ability to remove amyloid deposits from the myocardium, is there any way to non-invasively quantify amyloid reduction? Question about the nuclear scans, or are endpoints mostly surrogates like wall thickness and strain?
Yeah, I think that's a very, very good question. I showed you the existing risk scores right now. So the existing risk scores really depend heavily on circulating serum biomarkers with BNP, troponin, and as well as renal function. And then diuretic dose also seems to be a strong marker. In terms of directly quantifying this, I think this remains an area of active research. I can tell you that so far the data for strain and changes in strain do not appear to be that promising. There was some studies from Adam Castano when he was at Columbia looking at the use of serial PYP at these patients. It's been a bit mixed. It does not, changes in PYP uptake do not seem to be predictive of outcomes. So I would say the most promising modality and what's really recommended, or I shouldn't say recommended, what's, what the ASNAC guidelines comment on is you can use cardiac MRI. And with cardiac MRI, this is going to be based on the extracellular volume of deposits, because this can follow amyloid over time. But clinically, I think it's very hard to justify doing MRIs on your patients over and over. But I would say if you really want to follow it, or a research question would be to really look at extracellular volume over time with MRI.
A couple of the attendees have asked questions about AFib. So I'm going to read out Doug Levy's question. How aggressively do you pursue a rhythm control strategy for AFib in patients with amyloid, and how successful is catheter ablation in the population? That issue about ablation was asked a couple times.
Yeah, I think these are all very good questions. So what I would say is we have limited data. You're going to hear me say that repeatedly about TTR amyloid, which is one of the reasons why it's so exciting to be in the field. So there's so much emerging research. Specific for rate versus rhythm control, that series from Mayo Clinic shows when you cardivert them immediately, the early success rates are the same, whether you have amyloid or not. Other studies have shown that over time, recurrence rates are going to be much higher. And I think this ties in nicely, for example, in Nazim's work, where we know that all these patients got fibrosis everywhere in the atrium. You're going to have amyloid everywhere. So rates of recurrence are going to be higher. Specific to ablation, there's data from Maz Hanna's group at Cleveland Clinic looking at this. And what they showed is catheter ablation appears to be safe. It can be effective compared to no ablation, but compared to other cohorts, the rates of recurrence are going to be higher over time, not surprisingly. So in other words, you can consider it, but your patients are probably going to go back, or they're more likely to go back into atrial fibrillation.
And okay. One question here from Jeff Probstfield. Do you have more specific indications for the use of the spironolactone in those with preserved EF? It came from the slide you showed early. Maybe just talk about, are there groups of these patients you believe do better, or you routinely put them on, or what do you recommend about spironolactone?
Yeah, so I mean, again, I think the data is limited. In our own study, we showed no benefits, and the retrospective analysis of TopCats in a cohort enriched for cardiac amyloid, keep in mind that they did not confirm the diagnosis. There appeared to be benefits. So also clinically, I try giving it to my patients routinely, because I assume, sequential nephron blockade is going to help with their diuretic properties of loop diuretics, but also for potassium sparing. But at the end of the day, I think we don't have sufficient data to say whether it really impacts outcomes long-term. But in general, it's pretty well tolerated. There's minimal hypotension with spironolactone, as you all know, so I don't see why you shouldn't use it.
Okay. Thanks, Richard. We're at end of time. There's another couple of questions here in the chat that if you have a moment, maybe stay on. But I'd like to thank you for a great presentation this morning. Thank everyone for attending.
Thank you very much.